Today we learn to approach a case of injury around the elbow. So here is a child or a young person or an old person who falls on an outstretched hand or hand with flexed elbow, a point of elbow, and has pain, swelling, deformity, and loss of function around elbow. At the roadside, you are expected to grossly reduce the fracture, look for neurovascular deficit, record it, put the patient ill orally, splint, apply Sumag if there is swelling, elevate the limb, promote active finger movements, and then transport the patient to the hospital with full information. In the hospital, you evaluate, do what has not already been done, and in the evaluation, you record the patient characteristics, name, age, sex, address, handedness, education, occupation, any associated injury, comorbidities, socioeconomic resilience, that means ability to bear the expenses of treatment, and rehabilitation potential. Injury characteristics, which is the likely fracture. For example, if it is a supracondylar fracture, then there will be the relationship of the three bony landmarks, the olecranon and the medial and lateral epicondyle, will be maintained but altered in relation to the arm. There will be tenderness on the supracondylar ridges here or irregularity. In an intercondylar fracture, the intercondylar distance would be increased, this distance. In medial or lateral condyle, again the intercondylar distance would be increased, but the relationship of that particular condyle with the olecranon will be increased, the other side would be normal. And the tenderness would be on that particular condyle or epicondyle, not on both condyles. So this is medial and lateral condyle and medial epicondyle. Then capitulum fracture, there will be a bony prominence medial to the brachioradialis. From here there is the brachioradialis, so medial to the brachioradialis in the cubital fossa, there will be a bony prominence and tenderness. Then the fracture of the head of the radius. In the head of the radius, behind the brachioradialis, supposing this is the elbow, and here is the brachioradialis. So behind the brachioradialis here, there will be tenderness, and on pronation, supination, this tenderness would increase. Same, if it is a child, it is a fracture neck of radius. If it is an adult, it is the head of the radius. So here it is the child, and here you have the adult. Okay. Then the coronoid or the olecranon, there will be tenderness at that point. Then there is a fracture which is called as Montague fracture. In the Montague fracture, the ulna is fractured, and if it is anteriorly angulated, the head is dislocated anteriorly. If it is laterally angulated, then the head is dislocated laterally, and if it is posteriorly angulated, the head is dislocated posteriorly. So this is the fracture and dislocation. Fracture of the shaft of the ulna with dislocation of the head of the radius. So these are the summary of what I have just said. Relationship of the three bony landmarks maintained, altered in relation to the humerus. Tenderness in the supracondylar ridge. So you must be able to say, using these as to why you are saying that it is that particular fracture clinically. Now, so Here you see the head of the radius, the tenderness is between the extensor carpi ulnaris and posterior border of the ulna. And so this finishes the differential diagnosis of injury around elbow. Then in this you must look for vascular insufficiency or acute VIC. Pain, pallor, pulseless, paresthesia, paralysis. These 5 P's. And this suggests an acute VIC. As a result of an acute VIC or acute vascular insufficiency, the muscles would undergo necrobiosis and fibrose. The main muscle which fibroses is flexor digitorum profundus. So it can lead to a DIP contracture, then a PIP, then a MP contracture, and finally there is a wrist contracture. Because this tendon crosses all these joints. If you increase the wrist dorsiflexion, the contracture would increase. This is called as a tenodizing effect. Now then there are the 3 nerves. Then this tenodizing effect you use, this increase of contracture on wrist dorsiflexion, this you use to differentiate it from a Dupuytren's contracture, which is a contracture of the palmar aponeurosis distal to the radius. Contracted structure is not crossing the radius. Then this is the test of nerves. The median nerve supplies the first and second flexor digitorum profundus, leading to a pointing index test. Pointing index test. All the rest of the fingers are flexed, and there is a pointing index test. Then abductor pollicis, there is this pen test. So you place a pen here, and if he is able to abduct, this is called as the pen test. Then the ulnar paradox, because the flexor digitorum profundus 3rd and 4th is paralyzed in ulnar nerve palsy, high ulnar nerve palsy. Therefore, the claw hand deformity is reduced. Claw hand is flexion at DIP, flexion at PIP, and hyperextension at MP joint. This is the claw hand. Since the DIP flexion is reduced because of paralysis of 3rd and 4th, therefore the deformity decreases. Claw hand deformity decreases. So claw hand decreases, paralysis is higher. This is the paradox. Normally in a higher paralysis there should be more deformity, but here in a higher paralysis there is less deformity. Therefore that is the ulnar paradox. Then the flexor carpi ulnaris is wasted, palmar flexion and ulnar deviation of the wrist is affected. Abductor digiti minimi is wasted and paralyzed. Therefore, he is unable to abduct the little finger. This is called as the guava test. Then the 3rd, 4th lumbricals are paralyzed. This leads to clawing because lumbricals would flex the MP joint and extend the PIP and DIP joint. The opposite of this is hyperextension of the MP joint and flexion of the PIP and DIP joint. So extended MP, flexed PIP, DIP is clawing. Prolapse, then the intraossei, palmar intraossei adductors, dorsal abductors, these are paralyzed. You test them by the card test. The adductor pollicis is applied by the ulnar nerve. You test it by the book test or the Froment sign. The high radial nerve would paralyze the brachioradialis. There will be wasting here. The wrist would be dropped, which means extensor carpi. Carpi means wrist. Radialis longus, brevis, ulnaris. Then the MP joints will drop in extensor indices, digitorum, digiti minimi will be paralyzed, and abductor and extensor of thumb, extensor pollicis longus, abductor pollicis longus would be paralyzed, leading to a thumb drop. Other complications are malunion, myositis ossificans, Walkman ischemic contracture, and stiffness of the elbow, forearm, wrist, fingers, thumb, shoulder, and there is pain. Now, how would you investigate this case? You would assess the general condition for fitness, specifically for comorbidities, and you would image for the fracture in the distribution. Supracondylar fracture you will reduce. In general anesthesia, there is traction, counter traction with elbow 30-degree flex to avoid injury to the median nerve. Then you put pressure on the distal fracture parallel to the olecranon, forward pressure. The proximal fragment is pressed backwards, and then you flex the elbow 5 degrees short of obliteration of radial pulse, maintaining the traction along the humerus. Then you pronate completely to avoid cubitus varus deformity, which is the commonest reason of malunion around the elbow. You rotate completely internally and externally to avoid any rotation malalignment. And then you give above elbow POP cast with bridge bandage across the elbow. In an unstable fracture, you may fix the fracture with a transcondylar cross K wire. Then you retain it by elevation, active finger movement. Move all the joints not mobilized through complete range every day. Gives analgesics and anti-swelling, which is optional. You rehabilitate after the union is sound by no stretching, no massage, only active movement to restore elbow movement and pronation and supination. You treat the complications, most important being acute VIC where the limb may be lost. You remove the bandage. You recognize by the 5 P's: pallor, pulseless, paresthesia, paralysis, pain. On stretch, you remove any bands in the bandage, splint or plasters. You grossly reduce the fracture and extend the elbow. Give sumac if there is swelling. Elevate and cast it in elevation. Then you do active finger movements, and you can give drugs to decrease swelling, and you can use vasodilators and blood thinners to increase circulation. So you observe the circulation and you can monitor, quantify it by a pulse oximeter. Supposing the circulation does not come back, you can use anti-sympathetic drugs and you can do a sympathetic stellate ganglion block at the root of the first rib. Still doesn't come back, put the patient on general anesthesia. Incise the cubital fascia, the bicipital aponeurosis, anterior to the elbow. Supposing here is the arm and here is the forearm and here is the insertion of the biceps on the radial tendon. There is a bicipital aponeurosis here under which runs the artery. So you have to incise the bicipital aponeurosis to decompress the brachial artery and the median nerve. Then you can do a arteriography or a Doppler to recognize exactly where the compression is. Then you expose the artery, decompress it. Any bony fragment, any edema, any fascia You expose the artery so it's decompressed. Pulsations return, you do nothing further. Don't return, then you start from the pulsating area and go to the non-pulsating area. That is the site of block. If there is a thrombus or an embolus, you do a arteriotomy, put a Fogarty's catheter and pull the embolus out. If there is spasm, put local anesthesia, there may be sympathetic paralysis and the spasm may go. If it doesn't go, you do an arterectomy. You see, this is the adventitia, this is the artery, and these are the sympathetic fibers. So if you do an arterectomy like this, the sympathetic fibers will be cut and the spasm will be relieved. And you can resuture the artery, so the arterial circulation would be restored. Now, if the spastic segment is big, small, you may resect it and resuture it. You may need to mobilize the elbow and or the artery to prevent suture under tension. Now, if there's a big spastic segment, you can use a reverse venous graft. Why reverse? Because to take care of the valves. Now, in a chronic VIC, the flexor digitorum profundus and flexor pollicis longus and pronator teres have undergone ischemia and have fibrosed. So the FDP flexes the DIP joint, then the PIP joint, then the MP joint, and then the wrist. And pronator would prevent complete supination. So what you do is a flexor pronator release. So when you want to release the pronator teres, you can initially try to stretch it by a turnbuckle splint. But if that fails, you release the humeral head, you release the ulnar head. When humeral head releasing, you save the median nerve. When the ulnar nerve, then you save the ulnar nerve, you save the ulnar artery. So ulnar head, save the ulnar artery, humeral head, you save the median nerve. Then you release the flexor digitorum profundus. You excise the muscle sequestrum formed by the flexor digitorum profundus and flexor flexor pollicis longus and flexor digitorum profundus and you decompress the median nerve. So this decompression is called as Seddon's operation and that is called as Max Page operation. So this is the treatment of VIC. You can do bone shortening, proximal row carpectomy, distal row carpectomy, total carpectomy, or radial or ulnar shortening. Then myositis ossificans is subperiosteal calcified hematoma. This is the definition. This happens under brachialis. In the acute phase, there is a cloud-like appearance. In the chronic phase, there is a consolidated bone block. Acute phase, you rest and immobilize. In the chronic phase, you resect the bone block. Malunion, you do corrective osteotomy at the cora above the tip of the olecranon if that is symptomatic. So this covers the elbow.